Well, thank you so much for inviting me here today. I'll try to be brief and try to make you understand what cystic fibrosis is. That's the outline of what we're going to briefly discuss in 20 or so minutes. What is cystic fibrosis? The three slides that you see there are taken from the CF Foundation. If you have any doubt about cystic fibrosis, the best place, the best resource that you have is cff.org. It has the most updated information of any kind. There's education materials in at least 2 languages, English and Spanish, and the latest information on clinical trials, medications that are under study, medications that are available, patient support, information for providers is all there. So what is CF? Progressive genetic disease. This is a condition that comes with your genes. And in a nutshell, affect 2 main systems, your lungs and your growth. Your intestinal system is affected by malabsorption, so the patient might present with failure to thrive. And because of we're going to see in a few minutes, the inability to manage, have an adequate amount of fluid in your lungs, essentially mucus, that leads to an ongoing inflammation, infection, and then lung damage. As I said there, in the lungs, the mucus clogs the airways, traps the bacteria, and becomes a vicious cycle. We're going to review in a few minutes. So what are the symptoms that the patients present? Salty skin. The sweat is salty, and that is due to the abnormal function that the gene confers to the cell to deal with salt and water. So in the skin, the patients with CF will have a salty sweat. As the problems with the lungs start to develop, the patient will develop symptoms. The most common symptom is cough. The patient might be confused with having asthma, or chronic bronchitis, or reactive airway disease, or recurrent pneumonias, or walking pneumonias. All those are names that we refer to patients who are having persistent recurrent respiratory symptoms. Some of those names mean diagnosis, asthma, bronchitis, but it might just be a description of the symptoms that are ongoing, and that's the hallmark for patients with CF. Infections are the norm, as the patient have not an immune deficiency. The patient is very normal in the ability to fight infections. He's just more prone to acquire infections because of it's like having an open wound. You have a skin that is intact, no burn. The chances of having an infection are much lower. But that skin is not cared, it's dirty, or it's open, then the chance of having an infection is higher. So it's not an issue of you have poor defenses. It's that the milieu, the environment where the infection can occur is favorable. Wheezing is another issue that you can have. And then for nutrition, as the patient have adequate intake, the amount of losses that the patient has lead to a net loss of energy available to their growth. So the patient usually present with failure to thrive and also with associated symptoms, usually bloating, gassy, foul-smelling stools, and abundant stools that are greasy. So how this is produced? This is the genetics in a very, very simple slide. 2 parents, each one is a carrier. So the mother and father figure there are representing the 2 chromosomes. One in gray is normal, one in yellow is the mutation. To have the disease, you need to have the 2 mutations. So you will see 4 possibilities that the roulette comes every time that you are conceiving a child. If the parents are both carriers, there's a 25% chance, 1 in 4, that combination will lead to a patient or a child with cystic fibrosis. There's 50% chance that the child will develop or will be a carrier. A carrier does not confer disease. It's like sickle cell trait of sort. You carry the one mutation, but one mutation does not give you the disease. And then there's a 1/4 chance that the child will have no genes whatsoever. These are very complex slides. And unfortunately, my slides were split. So this is slightly easier to assess. So the mutation lead to the building of a gate. It's a protein. It's a door. The door function to allow the passage of a specific materials, salt, and not any salt, chloride. If that gate is not present, absent, malfunctioning, either by allowing very few molecules to go, or it's just shut door. It's there, but it's not, it's completely locked. Those are all consequences that will lead, all those are problems that will lead to a consequence. The mutant, what we call the mutant channel or gate, does not move the chloride, the salt, out of the cell. Remember, water follows the salt. We do those experiments in probably elementary school or middle school. You put a partial cellophane membrane, you put salty water on one side and pure water on the other. The pure water will go to the salty side because it follows the solutes. So if you are not having enough water because there's not enough materials to attract the water, that mucus that should be very fluid becomes thick, sticky, doesn't move. We have a physiological brooms that are called the cilia. That cilia need an easy, slippery slope to move. If it's sticky, then it cannot work this function. That cilia moves very quickly, okay? It can move a particle of charcoal or pollen very quickly. You can see it on videos. So we have that moving on all the time. As we talk, as we swallow, that secretions move out of your lungs without even noticing. If you have a cold, the flu, the production of that mucus is much lighter. And then you see, hey, if that is not fluid, you know that you are in trouble because you cough more. You get infection. So that's the basic abnormal function of this gate. The mutation confers that. Another complex slide. The cartoon is just trying to depict that now we know more about what kind of consequences the mutation confers. There are over 2,000 mutations. The panel that Alabama has covers about 40 or so of those mutations. What happened with the other 1,900? They're not very common. So the panel, as it should be, aims for the most common mutations. Some of the mutations affect the base of the cell, meaning there's no production at all of this. The DNA is not able to read for what we call the RNA. And the RNA will make this protein within the cell. Then the protein needs to move to the cell membrane to be effective. Like you need doors here, and the doors are made in the factory. The factory is shut, or there's no factory. Okay? So all those processes, that assembly line is defective. And now we know, and you see in the left side here, you see there's at least several types of mutation. We classify about 6 different types of mutation. I know this is complex. Why this is important now than 20 years ago when I trained? Because now we have medications that are targeting a specific problems. Okay? There are mutations, like there's no drugs. There's a medication. Now we have drugs for that, carry that mutation. We have silicone to make the door move easier. That silicone is very expensive, about $300,000 a year, but it's a different matter. So this is just a sequence of problems. You have a defective gene, mutated. That leads to a protein that is called CFTR, long name for the Cystic Fibrosis transmembrane regulator, a gate in the cell membrane. That decreased the activity of moving chloride, salt, out of the cell, and making impossible or very difficult for the water to make more fluid the secretions. That leads to a bronchial obstruction. The mucus remains there. That mucus then, because it's like still water, attract infection. Much easier. If you have a running water, it will not get green or smelly. Well, those secretions that stay there get green and smelly because they get infected. Actually colonized. The infection comes later. Okay, and the infection is because the body reacts against the presence of bacteria. I need to clean that pool, and the pool is just an stench. And that develops infection. So that's the sequence in the lungs. Now I put two arrows there, gene therapy and restoration of function is the newest therapy we'll briefly touch in a few minutes. So how do we diagnose CF? That's why you're here today. Okay? We have the ability to diagnose CF by numerous screenings from the 1980s. April 18, on a Friday, was approved in the state, and it started on April 21st, 2008, in the state of Alabama. Well, it was a Monday. Why I know that? Because that's my birthday. If not, I have no idea. Okay, so you get the blood spot from the heel stick. That will measure two tests, the ability to have two tests. What is called IRT, which is the measure of an enzyme that is abnormal in that particular period of the time of the life, in newborns. It doesn't work when you are 3 years old. It doesn't make any sense to do IRT in a 5-year-old that you suspect CF. It's not going to be there. So you have a time frame of few hours or days that you will measure that, and it will be an indication of abnormality. Elevated, signal, okay, it's too high, we need to do the panel of mutations. That's the second step. If the panel of mutation shows at least one in this state, certainly two, then you probably seal the diagnosis. But it's a suspicion that the IRT is very elevated or the mutation panel is positive, the patient must be seen by the protocol done in this state by a CF center to be having a sweat testing. Now, there are several types of sweat testing. There's only two places that I know in the state of Alabama that perform the standard, what we call chloridometry testing. The other, many hospitals across the state have a screening test. It's called conductant or macroduct. The macroduct is the collection, but the analysis, to be certain, is only at Children's Hospital in Birmingham and at USA in Mobile. So the state has two centers. It used to have two centers. Now only has one approved to do that, which is Birmingham. So the family is called to be tested. If the sweat test is negative, we'll go back in a minute, the patient is released. The patient has a positive newborn screening, but the third step that measures the function, how salty the sweat is. Let's say for a moment that you have a suspicion that the gate is not working. Then you have a suspicion that the salt will be elevated. Then you need to see if that salt is really high. And that's the sweat test. It's a functional test. It doesn't say anything about what kind of mutation you have. Functional test. And that's still the gold standard. You might have two mutations, 508, which is the most common. Still, very unlikely that the sweat test will be normal. But that is the measure of the function of which is important because now medications are improving the function of the gate, of the door. Okay? So it doesn't matter if the door is ugly or you don't like the color, but it works, that's what matters. So this is the cases that have been diagnosed by newborn screening in the state. I believe that we have missed only 2 cases since the program has started, which is a very good success. They were false negative. The patient was indeed diagnosed with CF after several months or a couple of years with being negative. Okay? So we were expecting about 20 or 24 cases a year, and in fact we're seeing fewer. Okay? That might be something to do with the families, the parents to be knowing that what mutation they have. And they might make genetic counseling adjustment to do that. And this is the type of newborn screening that happens in the different countries and different states. Alabama has that light blue, which is called IRT DNA, as I mentioned before. But the other states that do IRT in the first 2 days or so of life, and then they repeat it again within 2 or 3 weeks. And then they do the DNA. That limits the number of patients who need to go to the sweat testing lab, but it's a bit more complicated because then you need to follow the baby for the second IRT. Good luck in some places, okay? And the other states have only the IRT, which is in the green, in the West Coast. And the Northwest, and that's all led by Washington State. So the diagnosis of CF, IRT DNA is elevated, lead to the DNA analysis, is elevated, go to the sweat test lab. And the sweat test is done, you put an stimulator, if you will, actually, you electrocute the kid, no, just kidding. You put some mild electrical current, you tell it it's gonna tickle, it tickles. It's put there for about 30 minutes, so you make the kid break a sweat. Some kids here are very cool, they don't break a sweat at all. Okay, and that's a problem because we need to get them sweat. So sending the patient for sweat testing requires some art. The patient needs to be hopefully well hydrated. If he's not well hydrated, then he might not sweat because he's dry. He's trying to control, keep his hydration good. If the patient is too cold, he's not going to sweat. So all those are tricks that the lab people try to get because it's not a painful test, but it's a time-consuming test because the kid needs to be ready. It's a baby. Sometimes it's too small. Sometimes it's too unsettling. So you spend the morning. It's done only in the morning because then the sweat that is collected is analyzed, and the result usually comes around 1 or so p.m. So the patient comes to the Children's Hospital clinic in the morning and spend essentially all day until it's seen in clinic, and if it's sweat that is negative, is released and to his pediatrician, and we get the information. Hopefully you get the information. And if it's abnormal, then we have a social worker who is the person in charge of the program, geneticist, Dr. Lowe's, who helped the family understand the genetic impact of this, and then a pulmonologist, me or one of my colleagues, to explain the family the positivity, meaning the diagnosis. It used to be that there were 3 levels that changed with the age. Now it's very simple. If the sweat test is less than 30, it's negative. And the test is 60 or more, is positive. And between 30 and 60 is indeterminate or intermediate. So that's, if it's, now the patient has a 40 or 50, probably is kept in the loop in our CF center to be retested again. Usually a couple of months, sometimes in a year. And there's a group of patients that it was mentioned at the beginning, CRMS. I'm not going to confuse you with more acronyms, but that is a patient who, we used to call it atypical CF. Now that we know the mutations and how the mutations are working, some of the patients might have CF by genetics, but they're not behaving clinically as bad. And some portion of them, you can't predict how they're going to behave clinically in the future. So that's what we call CRMS, Cystic Fibrosis Related Metabolic Syndrome. It doesn't say much. So sweat testing, less than 60 is positive, less than 30 is negative, and then you go through the process of testing the mutations. Let's say for a moment that the patient has only one mutation is discovered and the sweat test is elevated. So we have no question that the patient has CF. The sweat test is 100 positive. The gate is not working, salty. Only one mutation. Then we do additional genetic analysis. We go beyond the panel of mutations and we send that to a particular lab. There are several labs in the country where they do the full analysis over 1,800 or 2,000 mutations. And then we find the second mutation. It's important that each patient has the 2 mutations known because the medications that are coming in the future will be related to what mutation you have. Not all Tylenol work the same. Clinical manifestation. This is a very simple cartoon where the normal epithelia has very easy and effective bloom. Those are the cilia. As the secretions are getting accumulated, then you start to have problems. The secretions get accumulated, they get infected, colonized with bacteria, infection, inflammation. So this is the cycle. The chronic bronchial infection lead to airway damage. That's what we call bronchiectasis. That makes even worse for cleaning of the mucosa and the mucus secretions out. And they cannot move the secretions well. They develop coughing, inflammation, swelling. The patient might present symptoms of asthma. And then the damage continues to go. So it's a vicious cycle and a spiral that leads to lung damage, eventually death. Other systems involved, the most important is the pancreas. The pancreas is blocked. The enzymes that help us with digestion are unable to reach the intestine well because, again, the mucus in the pancreas is very thick. The liver might be affected in a similar fashion, so the bile, the bilious salts are not working properly. So how effective is your ability to absorb what you eat is limited. The vitamins are not absorbed well either, and then the patient have nutritional problems, poor caloric intake, and vitamin deficiency. Treatment. The main treatment is to treat the malnutrition and certainly protect the lungs from an accelerated damage. So you have this girl with the treatment. Just those are the ones that she received for her lung part. There's no pills, there's no other things. So it's a lot of a burden every day to be treated. Normally we recommend 2 sessions a day. So several hours of every day, Monday to Sunday, that the patient need to use. These are all medications or treatment that are aimed to decrease or diminish or slow the progression. They're not treating. Some of them, the chest PT doesn't slow or doesn't prevent the progression. It slows the progression. Prevent it in a relative manner because you keep the lungs healthier by removing the secretions, by avoiding the inflammation and limiting the infection because you keep the house clean. And for GI, again, supplemental nutrition, good nutrition, heavy in fat, limited in carbohydrate, sugars, and vitamin supplementation. And then enzyme replacement. They need to take enzymes every time that they have a meal or a snack. This is taken from the CF Foundation. It's called the pipeline. If the bar is all across the slide, means that it's available. It's currently available to all the centers in the country. It should be available to patients. So to move the secretions out, you have one medication called pulmozyme, Dornase alpha, which breaks the DNA of the mucus that are from cells that are dead there. And that is a very sticky substance. So you're trying to make that mucus thin by this particular medication, has been probably 25 years available. And then you put salty water as another way to thin the secretions. Those are available. Ibuprofen, Motrin or any other brand, also is available to decrease the inflammation. We use it very infrequently, the ibuprofen. This is medication that we use to control the chronic growth of infection. These are nebulized antibiotics or oral antibiotics. We cannot get rid of the infection once it's there. So we need to try to control the number of billions of bacteria. You have fewer, probably you can get better or stay better, healthier, than having all the time an uncontrolled infection. It's like asthma well controlled versus asthma flare. Nutrition, pancreatic enzymes, nutritional supplements, and vitamins. So this is new and future treatment for CF. This is very, very basic. We're trying to make what it works in the cell membrane, what it works in the factory line, and what it works in the design of the protein. So we have potentiators of the lubricants for the gate that is there, is present. We have it, but it's not working properly. We need to potentiate that. That's what we call potentiators. Then the door actually is round and this hole is square. We need to correct that, make it better. We have a door, but it's not very well designed. It's defective. We need to correct that. That's called the correctors. And then there's no materials to make the protein. So we need to have a production that is corrected. Okay? So this is what is currently available. 2 medications. One is ivacaftor, and the other is called lumacaftor and ivacaftor. Those are the genetic names. The brand name is Kalydeco, $300,000 a year. Orkambi is similar price. And this is treated to restore the CFTR function. We have in Alabama the particular mutation that is benefited with ivacaftor is G551D. About 10% of the patients with CF in Alabama have that mutation. That, given the Irish ancestry of the state, is more frequent, more commonly found in patients of Irish heritage. So Alabama has one of the highest percent of patients with G551D. Over 10%, generally it's about 4 to 5%. Most of our patients are on the medication, and it's provided by their insurance, including Medicaid. So we're fortunate to have that. Some families has refused to use it, but that's their choice as well. So this is what is available, and this is what is coming. These are current medications in development. UAB Children's is a significant partner in making medications available soon by the research. So the extension of the bar indicates how close is to be available to the parents, to the patients. We have what we call preclinical studies, and then phase 1, phase 2, phase 3. So that is to restore the CFTR function. These are not antibiotics. These are not enzymes. It's to make the gate working again. Make the gate be present, available. And this is really the future that is happening now. This is a cartoon from 2015, where the patient is taking some cells from their intestine, is creating an organoid. That organoid, then the cells are transformed from being terminal to being stem cells. Then those stem cells that are totipotential are introduced with a gene that is correcting the defect of that particular mutation. It's called gene editing. It's been in the news on the past couple of weeks. And then that organelle is back to the patient. That's the future. And it's currently being studied at NCF as well. I think that's my last slide. Thank you.